Welcome to the deep dive. Imagine this. Maybe your dog, perfectly fine yesterday, is suddenly just off. Lethargic, maybe you notice some odd bruises. Or, worse, bleeding from the gums. It's terrifying.
It really is.
Today we're taking a deep dive into a set of your sources, research papers, articles, some notes, all looking at a condition that could cause exactly that. Immune thrombocytopenia in dogs and cats too.
That's right. And our goal here with this deep dive is to really unpack what's going on inside a pet's body when its own immune system turns against, well, a vital part of its blood.
Okay.
We'll explore the mechanics, the sometimes tricky path to diagnosis, and the pretty intensive treatment involved, all based on the material you've gathered.
And your sources make it super clear this is not some minor thing. Immune thrombocytopenia, IMT for short, is potentially life-threatening. It's an autoimmune disease. And one phrase that really stuck out to me was diagnosis of exclusion. That tells me right away, this could be like detective work, isn't it? Ruling things out.
Exactly. That's the core challenge. It demands a really systematic approach. So we'll be digging into everything your sources mention, from those tiny little platelets in the blood all the way to the long-term strategies vets and owners need to handle together.
Okay, let's start right at the basics then. Lay it out for us. What exactly is immune thrombocytopenia?
Okay, so fundamentally, IMT is an autoimmune disease. The body's immune system, which should be fighting off infections, right?
Yeah.
It mistakenly identifies the animal's own platelets as foreign invaders, as threats, and it starts destroying them. And platelets are these tiny cell bits absolutely essential for blood clotting.
So the immune system goes rogue, attacks the platelets, and then you just run out. You end up with really low numbers.
Precisely. That leads to a severe drop in circulating platelets. That's the thrombocytopenia part. And when that count plummets, the pet is suddenly at high risk for spontaneous bleeding, which can be really dangerous.
Wow.
Now, your sources make a key distinction. There's primary or idiopathic IMT, often called PIMT. Idiopathic just means we can't find any specific underlying cause.
So the body just decides to attack its own platelets for no apparent reason.
Kind of, yeah. It seems that way, out of the blue. That's primary IMT. But then there's secondary or associative IMT, and your sources say this is actually more common, especially in cats.
Okay.
In secondary IMT, the immune attack is triggered by something else. Could be certain infections, maybe some drugs, underlying cancer, or even other immune diseases like lupus SLE.
So finding that trigger is vital in those cases.
Absolutely critical. If you can find and treat the trigger, you might resolve the IMT.
I also saw something called Evans syndrome mentioned in the sources. What's that about?
Yes. Evans syndrome is particularly serious. It's not just IMT. It's when IMT happens at the same time as immune-mediated hemolytic anemia, IMHA.
So attacking red blood cells too.
Exactly. The immune system is waging a war on two fronts, destroying platelets and red blood cells. This combination, as your sources note, is much harder to treat and generally carries a poorer prognosis. It's a double whammy on the blood system.
Goodness, that sounds incredibly complex. Okay, so how does this attack actually work? Like on a cellular level? What's the process described in the sources?
Right, the pathophysiology. Yeah. Your sources lay it out pretty well. It kicks off with autoantibodies. The immune system produces these antibodies, often the IgG type, and they, for reasons we don't fully get in primary IMT, attach themselves to the surface of the pet's own platelets.
Kind of like putting a kick me sign on them, marking them for destruction.
That's a good way to put it, yeah. Once these platelets are coated with antibodies, they're essentially flagged as bad or foreign. Then scavenger cells, called macrophages, recognize them. And these macrophages rapidly remove the antibody-coated platelets from circulation. This destruction happens mostly in what's called the mononuclear phagocytic system, think primarily the spleen and the liver. They act like filters, pulling these flagged platelets out.
So platelets usually last, what, a week or so? But here they're getting pulled out almost immediately.
You got it. Normally, a platelet circulates for maybe 7 to 10 days. In IMT, your sources say that lifespan can shrink down to just hours. The body is just clearing them out incredibly fast.
Wow.
And while destruction is the main issue, the sources also mention that in some severe cases, the trouble goes deeper. The antibodies might even attack the megakaryocytes in the bone marrow.
And those are the platelet factories, right? The cells that make platelets.
Exactly. They're the precursor cells. So if they get attacked too, it's a double hit. You're destroying platelets faster and you're producing fewer new ones.
That sounds bad. Does the body try to compensate?
Oh yeah, it definitely tries. The bone marrow senses the low platelet count and ramps things up. It increases the number of megakaryocytes and boosts platelet production. That process is called thrombopoiesis.
But I'm guessing, based on the symptoms, that ramped up production often just isn't enough.
That's usually the problem in severe IMT, unfortunately. The immune destruction is just so fast, so efficient, that even a bone marrow working overtime can't keep up. The result is that dangerous level of thrombocytopenia.
Okay, that clarifies the how.
Hmm.
Now, who tends to get this? Your sources mention dogs and cats, but is it more common in certain groups, and what does it actually look like?
Yeah, so based on your sources, primary IMT is seen most often in middle-aged dogs, and there seems to be a sex link. Females are apparently about twice as likely to get it as males.
Interesting. Any particular breeds that are mentioned?
Yes, the sources list a few predisposed breeds: Cocker Spaniels, miniature and toy poodles, Old English sheepdogs, golden retrievers. But, and this is really important, they stress that any dog breed can be affected. It's not exclusive to those.
Okay. And cats? You said secondary is more common.
That's right. Primary IMT seems pretty rare in cats. When cats get immune-mediated low platelets, it's much more likely to be triggered by something else: FALV, FIV, maybe certain infections.
Gotcha. So the signs. If an owner is watching their pet, what are the warning signs, the red flags?
Well, the clinical signs are almost all related to poor blood clotting because of those low platelet numbers. And how bad the signs are usually depends on just how low the count is. Often, in pets showing symptoms, the count is well below 50,000 per microliter, and frequently it's, critically low, under 10,000 sometimes. Normal is way up over 150,000.
Wow, that low. So what kind of bleeding do you see first, typically?
The most common things are signs of surface bleeding. Your sources really highlight petechiae. These are tiny, pinpoint-sized red or purple spots. You see them best on hairless skin belly, inside the ears maybe, or on mucous membrane.
Mucous membranes, like gums.
Exactly, gums, the whites of the eyes, the conjunctiva sometimes around the vulva or prepuce. Seeing those little petechiae is a classic sign of severe thrombocytopenia.
Like tiny little bruises, almost.
Yeah, and you can see larger bruises too. Those are called ecchymoses. Other common signs are things like nosebleeds, epistaxis, bleeding from the gums when eating or even spontaneously. Signs of bleeding in the gut.
How would you know that?
You might see black tarry stools, that's melena, it means digested blood, or sometimes fresh red blood in the stool, hematochezia. Blood in the urine is hematuria, and bleeding into the front part of the eye is called hyphema.
Okay, so lots of potential bleeding signs. What about other symptoms beyond the obvious bleeding?
Well, if there's significant blood loss, even internally where you don't see it directly, the pet can become anemic. So they might be lethargic, weak, have pale gums. Sometimes, less commonly, you might see things like poor appetite, maybe a fever, or enlarged lymph nodes or spleen, especially if it's secondary IMT or the spleen is working overtime destroying platelets.
Are there types of bleeding that are, particularly worrying signs?
Yeah, thankfully less common, but definitely more severe, is bleeding into really critical places. Hemorrhage into the brain or central nervous system, for example, is very bad news, guarded prognosis there. Same for bleeding into the lungs, which causes breathing problems. Bleeding into body cavities like the abdomen is rare, but also very serious.
Okay, so if vets see some of these signs, suspects low platelets, how do they start that diagnosis of exclusion process you mentioned earlier? Where does the detective work begin?
Right. This is where the systematic approach detailed in your sources comes in. The absolute first principle is confirm the thrombocytopenia is real and severe, and then methodically rule out everything else that could cause it before landing on primary IMT.
Step 1. Confirm the low count. Sounds simple? Maybe not.
You'd think, but it's actually got a critical nuance. So yes, the first test is usually a complete blood count, a CBC. The machine gives you an automated platelet count, and in IMT, it'll usually be very low. However, and your sources are emphatic about this, you absolutely must follow that up with a manual review of a blood smear under the microscope.
Why? Why is looking at the slide so crucial if the machine gives you a number?
Because the machine can get it wrong. Looking at the smear is vital to rule out something called pseudothrombocytopenia. What happens is sometimes platelets clump together in the blood collection tube. This happens a lot in cats, actually. The machine sees that big clump as just one large particle, not thousands of tiny platelets, so it reports a falsely low number. The vet looking at the smear can see those clumps and know it's an artifact, not true thrombocytopenia. Your sources even mention potentially using a different type of blood tube, like one with citrate anticoagulant, if clumping is suspected.
That's fascinating. So the machine can be fooled, but the human eye Checking the smear catches it. What else can you see on that smear?
It tells you a lot. You look at the platelet morphology, their size and shape. Are there unusually large platelets, sometimes called macroplatelets? Seeing those big young platelets is a really good sign, actually,
How is that a good sign?
because it means the bone marrow is responding like crazy, churning out new platelets as fast as it can. It suggests the factory is working and the problem is likely destruction, which fits with IMT. The smear also lets the pathologist check the other blood cells, red cells, white cells, and look for any abnormalities, or even infectious organisms hiding inside cells, like Ehrlichia or Anaplasma.
Okay, so confirm the count, double check with a smear, rule out clumping, look for big platelets. What about tests specifically for bleeding function?
Right. Some basic bleeding tests are usually done. The buccal mucosal bleeding time, or BMBT, where they make a tiny cut on the gum and time how long it bleeds, will be really prolonged if platelets are severely low. But a coagulation profile tests like PT and APTT, which measure different clotting factors, should actually be normal in pure, uncomplicated primary IMT.
And if they aren't normal?
If the PT or APTT are abnormal, that points the investigation elsewhere, towards more complex clotting disorders, maybe something like DIC, disseminated intravascular coagulation.
Okay, so PTAP-PTT normal, confirmed low platelets on smear.
Yeah.
Now the hunt for secondary causes begins in earnest.
Exactly. Now, the real detective work starts. You have to systematically rule out potential triggers. Infectious diseases are high on the list. Testing for tick-borne diseases is common. Ehrlichia, Anaplasma, Babesia, depending on the region. For cats, FAV and FIV testing is essential. Maybe brucella testing or fungal tests if there's suspicion based on history or location.
What else do you look for?
Imaging plays a big role. Chest x-rays, abdominal ultrasound, you're looking for hidden tumors, signs of internal bleeding, maybe an enlarged spleen or liver that could be part of the problem or suggest an underlying disease. And a really thorough drug history is crucial.
Asking about everything.
Everything. Prescription meds, supplements, even flea and tick preventatives. Some drugs are known to be able to trigger secondary IMT.
The sources also mention bone marrow evaluation being strongly recommended sometimes.
Yes, a bone marrow aspirate or biopsy can be incredibly informative, especially if things aren't straightforward. It's strongly advised if other blood cell lines are also low, like anemia and low white cells too, pancytopenia, or if the pet isn't responding to initial treatment like you'd expect, or if abnormal cells were seen on the blood smear.
What does the bone marrow tell you in IMT?
It gives you a look inside the platelet factory. In classic IMT, you usually see normal or even increased numbers of megakaryocytes. The marrow is trying its best to make platelets, which supports the idea that the main problem is destruction outside the marrow.
And if you don't see that, if megakaryocytes are low,
That's a really important finding. Decreased megakaryocytes suggests the problem is, in the factory, a production issue, not just destruction. That points towards a different diagnosis entirely. The marrow evaluation also helps rule out really serious things like leukemia or cancer infiltrating the marrow.
okay. Now, what about those tests that specifically look for the antibodies stuck to the platelets? PAI tests. Are those the key diagnostic tool?
This is where your sources offer a bit of a surprising perspective. While these platelet-associated antibody tests exist, they're actually considered pretty controversial in the veterinary world. Routine use for diagnosing primary IMT is generally not recommended by the experts cited in your material.
Really? That seems counterintuitive. Why wouldn't you test for the antibodies causing the problem?
Well, the issue highlighted in your sources is specificity, mainly. These tests can be positive in dogs with primary IMT, sure, but they can also be positive in dogs with secondary IMT caused by something else, and sometimes even in dogs with other diseases that aren't IMT at all.
So a positive test doesn't guarantee it's primary IMT.
Exactly. And a negative test doesn't rule it out either. They just aren't reliable enough on their own. Your sources actually emphasize that a positive response to immunosuppressive treatment is often considered a much stronger diagnostic indicator for IMT than the PAEG test result itself.
Huh? Okay, that's really interesting. So diagnosis is truly a puzzle, putting pieces together, ruling things out. Once you arrive at that likely diagnosis of IMT, what does treatment look like? It sounds like it needs to be aggressive.
Extremely aggressive, yes. The goals are basically threefold. Stop the immune system from destroying more platelets, control any active bleeding, and try to prevent it from happening again. This means significant immunosuppression and a lot of supportive care, often starting in an emergency setting.
So what happens if a pet comes in bleeding? Critically low platelets. What's the immediate plan?
Emergency stabilization is key. First, Strict rest cage rest, usually to minimize any chance of injury or triggering more bleeding. Then, blood products are often critical.
Like platelet transfusions.
Ideally, yes.
Yeah.
Platelet-rich plasma, PRP, or platelet concentrates, are the best way to directly increase the platelet count quickly. But there are catches. Availability can be limited, and the effect is very temporary. We're talking hours.
Why only hours?
Because the pet's immune system is still active, and it destroys those transfused platelets just as quickly as its own. So it buys you time, maybe helps stop immediate bleeding, but it's not a long-term fix. Fresh whole blood is often more readily available. It provides some platelets, plus red cells if the pet is anemic, and clotting factors. Packed red blood cells, PRBCs, are just used if severe anemia is the main concern. They don't help the platelet count itself.
Are there other emergency meds besides replacing blood components?
Yes, your sources mention antifibrinolytic drugs like tranexamic acid or aminocaproic acid. These don't make new clots, but they help stabilize any clots that do form, making them less likely to break down. So they can help reduce ongoing hemorrhage in severe cases. And often, injectable fast-acting corticosteroids like dexamethasone are given right away to start the immunosuppression while waiting for oral meds to kick in.
Okay, so that's the emergency stabilization. What about the long-term fight against the immune system?
That's the core of the treatment, immunosuppressive therapy. And the absolute cornerstone, the first-line treatment according to your sources, is corticosteroids, usually prednisone or prednisolone, given at high doses initially.
High doses to really knock down the immune system.
Exactly. The goal is to shut down that antibody production and platelet destruction quickly. You keep the dose high until the platelet count starts to rise consistently and reaches a safer level, often aiming for over 50,000, ideally over 100,000 per microliter, and stays there.
And once the count is up in a safe zone, you can stop the steroids.
Absolutely not.
Yeah.
This is probably one of the most critical points your sources emphasize for owners to understand. Once the count is stable, the steroid dose has to be tapered down incredibly slowly. We're talking over weeks and more likely months.
Months?
Yes, minimum 3 to 6 months is what your sources suggest, often longer. Tapering too quickly is a very common reason for the disease to relapse. The goal is to find the absolute lowest dose that keeps the platelets up, maybe even switch to every other day dosing, and hopefully eventually get the pet off steroids completely. But it has to be gradual.
And steroids have side effects, right?
They certainly do. Increased thirst, urination, appetite, panting, weight gain, risk of infections. It's why vets often prescribe gastroprotectant medications alongside high-dose steroids to help prevent stomach ulcers, which can be a serious complication.
What if the steroids alone aren't working well enough, or the side effects are just too much for the pet or owner to handle at those high doses?
That's when second-line immunosuppressants come into play. These are added on top of the steroids, or sometimes allow the steroid dose to be lowered faster. They're used in severe cases, refractory cases, ones not responding, sometimes in very large dogs where steroid side effects can be extreme, or if a pet relapses.
What kind of drugs are we talking about?
Your sources mention a few. Vincristine is sometimes used early on, especially with severe bleeding. It can sometimes cause a surprisingly rapid, though often temporary, increase in platelets within a few days, possibly by affecting megakaryocytes or platelet release.
Interesting. What else?
Cyclosporine is another common one, often used if steroids aren't enough or side effects are bad. It takes a few weeks to reach full effect, though. Azathioprine is another option, often combined with steroids in dogs again, takes weeks to work, and needs careful monitoring for side effects like bone marrow suppression or liver issues. And importantly, azathioprine is contraindicated in cats, very toxic to them.
Okay, no azathioprine for cats. Any other options?
Yes, mycophenolate mouvetil is another immunosuppressant, might work a bit faster than azathioprine. Leflunomide is sometimes used for refractory cases. And for really desperate, life-threatening situations where nothing else is working, there's intravenous immunoglobulin affiggage.
How does IMB work?
It basically floods the system with antibodies that temporarily block the receptors on those macrophage cells that destroy platelets. It can stop the destruction quickly, but it's incredibly expensive, the effect is temporary, and there's a risk of allergic reactions. It's usually a last resort.
Wow. Okay, beyond the immunosuppressive drugs, are there other treatments or interventions?
Well, the absolute most important thing for secondary IMT is to treat the underlying cause, if one was found. That's key.
Right.
Sometimes antibiotics might be used prophylactically if a pet is severely immunosuppressed and at high risk of infection. And then there's surgery splenectomy.
Removing the spleen. Why?
Because, as we said, the spleen is a major site where those antibody-coated platelets are destroyed. Removing it can significantly help control the disease in some pets, especially those who are refractory to medications. But it's major surgery, obviously, with its own risks and implications.
Your sources also hinted at newer drugs.
Yeah, briefly mentioned things like thrombopoietin receptor agonists. These are drugs used more in human medicine for ITP, the human equivalent, that directly stimulate platelet production. They're still considered more investigational in pets, but might be an option for very difficult cases under specialist care.
Okay, so this is really intensive process: diagnosis, emergency care, long-term medication, potential surgery. What does this all mean for the pet's prognosis? Can they recover fully?
For dogs, the outlook described in your sources is actually cautiously optimistic, let's say. With prompt, aggressive treatment, the prognosis is generally considered favorable to good.
Really? That's good to hear.
Yeah, the response rates to the initial steroid therapy are pretty high. Somewhere between 70 and 90% of dogs will show a good increase in their platelet count, usually starting within about 4 to 7 days. And overall survival rates are often quoted in that same 70 to 90% range for dogs who get through the initial
Right.
crisis.
That's much better than I might have guessed, given how serious it sounds.
Mhm.
But there's still that 10–30%. What happens there? What are the risks?
Yes, absolutely. There are significant risks. Unfortunately, up to 30% of dogs diagnosed might still die or need to be euthanized. This is often due to catastrophic bleeding, like a brain bleed that just can't be controlled, or sometimes due to severe complications from the treatment itself, like overwhelming infections because of the immunosuppression or serious GI problems from the steroids.
And relapse, is that common?
It's definitely a concern. Your sources mention relapse rates anywhere from about 9% up to maybe 31%. And importantly, if a dog relapses once, they seem to be at higher risk of relapsing again in the future.
Are there things that make the prognosis worse from the start, like warning signs?
Yes, your sources identify several negative prognostic indicators. Things like having melena, that digested blood in the stool when they first present. High kidney values, like BUN, on their initial blood work. Needing a blood transfusion right at the beginning. Finding decreased numbers of megakaryocytes on a bone marrow exam that points to a production problem, which is harder to fix. And as we mentioned, having Evans syndrome, where both platelets and red cells are being destroyed.
And what about cats? Is the prognosis similar?
For cats, it's often considered more variable and generally more guarded than in dogs. Remember, primary IMT is rare in cats, so it's often secondary to something else, which complicates things. Presentations can be severe, and response to treatment can be less predictable. Mortality can unfortunately be quite high, especially if they present with severe bleeding.
Okay. So how is a pet monitored through all this? It sounds like it needs really close watching.
Oh, absolutely. Monitoring is intense, especially at first. During the acute phase, when they're likely hospitalized, it involves very frequent checks, maybe daily or even twice daily platelet counts to see if the treatment is working. Checking their packed cell volume, PCV, regularly to monitor for anemia, keeping a close eye on vital signs, and just constant vigilance for any new signs of bleeding.
And then once they hopefully stabilize and go home,
The monitoring continues, just shifts more to outpatient and home care. It means frequent vet visits initially, maybe weekly at first, then stretching out to every 2–4 weeks as the medications are being tapered, then maybe monthly or quarterly long-term if they do well.
what happens at those visits?
Repeat lab work, primarily CBCs, to track the platelet count and make sure it's staying up as the drug doses come down. Maybe chemistry panels periodically to watch for steroid side effects on organs like the liver, sometimes retesting for infections if that was a concern initially. And crucially, the owner becomes the frontline monitor at home.
The owner has a big role then.
Huge role. They need to be watching constantly for any subtle signs of relapse, tiny bruises, bleeding gums, nosebleeds, lethargy, and also monitoring for potential side effects of the long-term medications.
It really sounds like a partnership between the vet team and the owner is essential for managing this. What are the absolute must-know things your sources say vets need to communicate to owners facing this?
Client education is absolutely paramount. Based on everything in your sources, vets have got to make it crystal clear right up front. This is a life-threatening emergency. It needs immediate aggressive action.
Okay.
Owners need to understand the concept of an immune-mediated disease that the pet's own body is causing the problem. That helps them understand why we need to use strong drugs to suppress the immune system.
And explaining that diagnosis of exclusion idea.
Yes, explaining why so many tests might be needed to rule out infections, cancer, other causes helps manage expectations and justifies the diagnostic process. And then hammering home the need for long-term treatment and that super slow medication taper. That's vital for preventing relapse.
What about dealing with the medications themselves?
Definitely need to educate owners about the expected steroid side effects. The drinking, peeing, hunger, panting, etc. Help them understand these are common, often manageable, and that the medication is literally life-saving, so they need to stick with it despite the side effects. And prepare them for the possibility that relapses can happen even with perfect management, and they need to seek help immediately if they suspect one.
What else is key for owners to grasp?
The sources mention being upfront about the potential cost, which can be substantial, especially with emergency care, diagnostics, potential transfusions, and long-term medication and monitoring. Explaining that blood products like platelet transfusions are really important for emergencies but only provide a temporary fix, the effect is transient, manages expectations there too.
And longer-term considerations. What should owners know moving forward?
Teaching meticulous home monitoring for bleeding signs is non-negotiable. Discussing the potential risks versus benefits of routine vaccinations going forward is important, maybe opting for antibody titers instead. Advising no breeding for affected animals as there might be a genetic component. And explaining when a referral to an internal medicine specialist might be beneficial for really severe, complicated, or refractory cases. It's a lot for an owner to take in.
Wow, it truly is. It's a marathon, not a sprint, managing this condition. A really challenging journey for the pet and for the people who love them.
Absolutely. It takes an incredible amount of dedication, vigilance, and partnership with the veterinary team.
So we've gone pretty deep into your sources today. We've explored what immune thrombocytopenia is, how the body mistakenly attacks its own platelets, the often subtle signs to watch for, that careful diagnosis of exclusion process, and then the really intensive, often long road of treatment and monitoring.
Yeah, and I think what comes through is that while it's undeniably a serious, potentially frightening diagnosis, the good news is that with that prompt, aggressive care and dedicated follow-through, many pets, especially dogs, really can have a favorable outcome. There is hope.
There is hope.
Yeah.
And, navigating something this complex, this demanding, for a pet you love, it really highlights the depth of that bond, doesn't it? It forces you to confront difficult choices, commit to these really rigorous protocols, become a true advocate for their health. So maybe the thought to leave you with is this. What does learning about the reality of conditions like IMT and the immense commitment required to face them head-on teach us about what responsibility and compassion truly mean in our relationship with the animals who share our lives?
That's a powerful question. It certainly underscores the profound nature of that commitment and makes you think about the lengths we're willing to go to uphold that bond even when things get incredibly tough.